My name is Sam Borden. My pronouns are she, her. I am the Harm Reduction Grant Fund Manager at the Colorado Department of Public Health and Environment, or CDPHE. You will be hearing from several of my colleagues at the state level as well, but we're basically going to be going through what our current funding mechanisms look like. I do want to make it clear, at least on my end, that this is the funding we use to operate our program, so I don't want anybody to riot if we're not telling you the funding that's available to you currently. Just fair warning. But hopefully this lends a little bit of clarity around what we're currently using to keep programs in place at a state or federal level. All right, so I am part of the overdose prevention unit at CDPHE, and basically this unit is comprised of several different programs in addition to just functions that we perform. But when it comes to our grant-funded programs, these are usually, we're receiving money from either a state entity or a federal entity, and then we're opening up a competitive opportunity for community organizations to take part in it. Some exceptions to that would be something like the Coroner Mini Grant Program or the Naloxone Bulk Fund. But just for a quick primer, we have the Overdose Data to Action Grant, which some of you may be familiar with. This is a federal... They've started. Spoiler. I told you though, right? All right, so our OD2A, or Overdose Data to Action, is our federal funding source. You may have this operating at a community or city level in your area as well. But this is a source of funding that we have used to then release additional funding for grantees across the state. It was something we felt was quite precarious given the federal landscape, and we did receive our funding for this year finally, but it was quite delayed. So we currently have that in place, luckily. This program will help with funding programs as well as data collection, best practices, and so it's been kind of a long-standing program for us. The Coroner Mini Grant Program is basically just, you fill out a Google form, that's your application, and you can receive some funds for your coroner program to test for extended substances. So usually those are substances that are co-occurring with opioids. They may be novel substances like xylazine. We know that coroners' offices are typically incredibly underfunded. And so we want to make sure that at the state level, we have the tools to provide to you all so that we can then ensure that we're getting some data our way that we can then share with our community partners. So it's this kind of mutually beneficial train of funds that we hope provides some additional support. The Harm Reduction Grant Program is my program. So this is a state program. It's funded through the Marijuana Tax Cash Fund. It was created in statute in 2019, and its intent was to primarily make sure that we were using other methods of keeping people safe, healthy, and alive, rather than routing them through the criminal legal system. It is kind of a unique fund in that, one, it is state funded. We may have all become familiar with something like the Sam Said Dear Colleague letter or some of the rhetoric at a federal level, but we are state funded, we are still operating, we are still focusing on harm reduction, and we also are allowed to have continuous appropriation, so we just started another 5-year cohort. I'm gonna need you all to knock wood for me that sticks around, because it's been really, really important. And then finally, I'm gonna go quite a bit more in depth on the Naloxone Bulk Fund today, because that's probably what many of you interface with most. But the Naloxone Bulk Purchase Fund is funded through a variety of different sources. Federally, state funding. We receive some funding from our partners here. They're great, thank you so much. So I'll go into a little more depth on what that looks like. All right, so those of you in the room, does anyone know what the Naloxone Bulk Purchase Fund is? Okay, that's promising. So sorry for being a little redundant, but hopefully this lends some insight or some reminders. So the Naloxone Bulk Fund was created in 2019. It is also in state statute. It allows for us to provide free naloxone to eligible entities across the state. It has been After that, our eligible entities were expanded. So originally when this was created in statute, we had a very small list of eligible entities, and then that got expanded quite far out. So at one point in time, we had American Rescue Plan Act funds, which were hugely impactful in making sure we could really saturate the community, really give out naloxone en masse to everyone who requested it. As time has gone on, and because our funding is so fluctuating year to year, we have had to create a prioritization plan. So that is one way that we've tried to remain good stewards of the money and also not diminish the response and the effect of the naloxone bulk fund. What the prioritization plan is, which some of you may be familiar with, is we've taken a look at who has the biggest impact on reducing overdose. And what we know from a large body of evidence is that it's people who use drugs. So we are prioritizing naloxone to people who are providing naloxone directly to people who use drugs and people who are going to be most likely to respond to an overdose. We would love to be able to just t-shirt gun naloxone at any point, so if anyone has some spare money they want to throw our way, let us know. But right now we're really leaning towards the evidence and making sure that we're getting this into the hands of those who are getting it to the people who will use it, who need it most, who are really the first responders in this epidemic. Sure, go for it.
Thank you so much. The thing I'm thinking about is that naloxone is covered under insurance. And I work at an opioid treatment program where we provide on-site methadone and Suboxone. Obviously, we're giving Narcan that we acquire in various ways, directly to those patients without prescription, without billing their insurance. I would love to have more conversations with BHA and other people about what it would look like for us to be able to write prescription for naloxone, provide it on site, and get reimbursed by insurance, because that would pay for it. Just curious if we could pursue that.
I think that's an amazing question, and there's absolutely a mechanism for that if you have an existing pharmacy on site. So it sounds like you're providing medications.
So we don't have pharmacists, and it's not an official pharmacy.
But you have prescribers.
But we have prescribers on site.
Okay. So yeah, if you have prescribers, they absolutely can write a prescription for naloxone to participants. And that has been long-standing for quite some time. There are, and I'll get into this a little bit more just in a second here, but there are various mechanisms for accessing naloxone. And one of those kind of ones that we've had to lean on for quite some time is insurance, right? For Medicaid, it was incredibly cheap to access injectable naloxone. And that was a huge boon for us when it came to getting that in the hands of people who needed it, who didn't have access to even enough money for a copay. Doctors absolutely can prescribe. It is now over the counter. There are certain naloxone products that are over the counter, so a prescription is not necessary. However, with the cost being a barrier, prescription is an important option still. So you're allowed to do that. You also can get a standing order from the state in terms of having that general, like we can have a blanket kind of prescription where we can just give our participants naloxone without having to have them go to a separate location. So if you are interested in learning more about standing orders, please talk to me or my colleague over here, Jericho Dorsey of Naloxone Bulk Fund fame. We also have a lot of information on our website, which I can share with you, but you definitely have an avenue there. All right, so this kind of brings me to the end of talking about this prioritization plan. Part of the prioritization plan, too, was looking at what mechanisms are in place right now for organizations who may no longer fall in Tier 1, Tier 2, like direct service organizations, to access naloxone, to distribute naloxone, for people to access naloxone. And so it's really encouraging community collaboration. So are you talking to your local syringe access program? Are you, a recovery service that's talking to them? You're for profit, so maybe you don't qualify for the naloxone bulk fund. Are you having communication with them where you can partner and not duplicate, but kind of have that referral network? If you're a hospital, are you bringing on local resource providers who can also provide that kind of connection to naloxone or other services? So that's something we're really encouraging for folks. And we are providing naloxone to a lot of those partners that we're discussing. And so we can kind of broker that with you too, should you reach out to us. We also know that naloxone is over the counter now in certain formulations. The cost is still inaccessible for many individuals, but if you are a for-profit organization, treatment center, hospital, you've never qualified for the bulk fund. So it is really incumbent upon you to prioritize having a budget for naloxone. We really encourage individuals to really invest in that. We do provide 4 different types of naloxone to eligible entities, and that allows a kind of range of choice for our participants. We try and work with what our bulk fund participants ask for within the confines of state price agreements and availability. So scroll down, move along. All right, so this is where I'm going to ask you to potentially give us some feedback. So this kind of aligns with your question as well. And we really are looking for some additional clarity about what would make this program work better. So in the last legislative session, we had a bill called HB 25-164 pass, the Opioid Antagonist Availability and State Board of Health. So prior to this legislative session, Colorado law provided a specific list of eligible entities that a prescriber may prescribe or dispense an opioid to, or an opioid antagonist to, which is naloxone. This act in the last legislative session got rid of that list and now requires the Board of Health to establish a new list with stakeholder feedback, with consultation with the overdose prevention unit, with consultation with state partners. And so we're going to be working on gathering feedback from individuals who are utilizing the bulk fund, who maybe are considering utilizing the bulk fund, who have never utilized the bulk fund, and just getting a sense of who they think should be eligible for standing orders, who should be eligible for the bulk fund. I will clarify that this process will not affect the prioritization plan in any way. That's a separate, non-statutory piece of how the bulk fund operates. If any of this is not clear, feel free to ask me about it when we get to questions, because I'm hearing it come out of my mouth, and I'm pretty sure it sounds like a real mix of understandable and not understandable lingo. But basically what we're going to be doing is we will be having stakeholder groups prior to meeting with the Board of Health and advising them on what we would like them to do based off of feedback. And so we really encourage you, if you have big feelings or some feelings, please reach out to us and we will make sure to engage you in this stakeholder process, because we want to make sure that we're actually getting feedback from the people who are using the fund, who may not be using the fund for very specific reasons. We want to make sure that even though we have limitations of funding and function, we actually are able to implement and cause the same impact on those who we know are most in need of naloxone. And the email's right there. All right, now funding the naloxone bulk fund. The naloxone bulk fund is interesting because it's always been a very popular program. It's a very necessary program because we're providing free naloxone, right, to entities that are serving those among us who are most likely to respond or need naloxone. But we've only really ever received one consistent form of funding, and that is $160,000 a year from the Joint Budget Committee. It sounds like a lot. It's not a lot. So we use that for administrative costs. That's basically funding our staff who places the orders, coordinates with the pricing system, makes sure that naloxone gets to people on time, and really kind of troubleshoots and works with folks. They also provide training, support, conversation. They're quite charming if you've interacted with them. Now, we have received a number of different funding options throughout the years. One of the most substantial was American Rescue Plan Act funding. We got a large amount of that money. But as many of you know, if you have received some of that money or you work with people who have, that funding expires and gets pulled back, right? We also spent that pretty quickly because we were really wanting to get naloxone out the door. And at that time, naloxone was also much more expensive. So we've seen a reduction in price, which is great. But we've also seen a reduction in that overall amount that we have available. So we start off with that $160,000 each year. Right now, we have current funding sources. We've got money generously donated to us from the Colorado Attorney General's office, their opioid abatement funds. We have state cash funds. These were formerly American Rescue Plan Act funds, so we do have some remaining. Those expire in 2026. We also have state opioid response or SOAR grants from SAMHSA via the Behavioral Health Association or Administration, and they've been an excellent partner as well. In the past, we've also had a patchwork of funding. So we've had Federal CARES Act, more ARPA, BHA block grants, Overdose Data to Action, Bureau of Justice Assistance, and Governor's Office interagency funds. So we're always kind of trying to pivot and make sure that we're filling the gaps. There's been a lot of concern and fear when the prioritization plan went into place that the bulk fund was going away. And that is very much never our intention. We put prioritization plan in place so that we can make sure that this fund can persist and get naloxone to the people who need it most. Ideally, we would love to give it to everyone that needs it, and so we're trying to be agile and flexible to kind of make sure that this fund can continue to go forward. And we are consistently looking for additional options that will help with the longevity of our work and make it a little less of a tangled web. Oh, I see a question.
Yes, thank you. My name is John, I'm with Recovery Friendly Leader. How do we put a request in to be an approved distributor?
That is a great question. So if you go to our website, which is, I cannot whip off the URL for you right now, but it's, if you go to the CDPHE website and you go to the Overdose Prevention Unit, do you know what it is off the top of your head? If you type in Overdose Prevention website, CDPHE, or Overdose Prevention Unit for CDPHE, there will be several links on there. One will be explicit to the standing order. One will be more specific, like broad for the naloxone bulk fund, and that's where you're gonna find all of the eligible entities listed. You'll have a step-by-step on how to access a standing order if you don't already have one. You're gonna have a link to the prioritization plan. And if you run into any questions when you're on there, you can just shoot us an email on that overdose prevention email, which I'll show at the end of these slides too, if, for a brief moment before I stop talking so my colleagues can begin to talk. Yeah. All right, so just wanted to share some outcomes. Even though our funding is a challenge, just like it is for, I'm sure, all of you, whether it's because of the current federal and state barriers that we're running into, or even in the past, this is not something that's particularly new to this world, we still are making an impact. And the reason that we are making an impact is because our partners who receive naloxone or receive funding through our other grant-funded programs are the ones on the ground doing the work, trusting us to provide support and collaboration as they really try and attend to this in the most person-informed way. So in FY25, which is for the state fiscal year, if folks are not familiar, is gonna be July 1st, 2024 to June 30th, 2025. We had 411,044 doses distributed, noting that this is also representative of a full year after the prioritization plan was implemented. So we're distributing to Tier 1 and Tier 2 agencies. And those are those who are providing directly to people who use drugs. We provided naloxone to 390 agencies, and that was in all 64 of Colorado counties. So we're really still seeing an impact. I will quickly go back and show you that year we spent about $6,150,209 on naloxone. So it comes with a pretty heavy price tag. We are seeing that monthly average go down a little bit because the cost of naloxone is going down, but we're still not quite comparable with, well, we're certainly not anywhere near comparable with the amount of funding that we would need to remove the prioritization plan at this point. Currently, we expect that we're gonna need about $447,000 every month to fund our current 2 tiers. So the challenge is there, but we are currently persisting, right? We're still meeting that need. Some other things to know about the naloxone bulk fund team and our unit in general is that we do provide training and technical assistance. There is a monthly virtual training. It's coming up on Halloween, our next one. So if you have teammates who want a refresher, you want to sit in on a training that just goes over naloxone administration, you want some opportunities to ask some questions, you're welcome to join those. We also have those training links posted on our website and in our newsletter if you're not already a subscriber. And then, like I've said before, we are very, very focused on both responsibly using these funds and making sure that this program persists. It is incredibly vital. We know that our partners have been doing this work without the bulk fund for years. They have been saving lives by being nimble and really adaptable to the limitations that are kind of set in place around accessing naloxone. It's been around since the 70s. So the fact that we really have only seen the uptick in use and people being really willing to consider it as a tool in the general public and the destigmatization is a huge thing to consider. And so we will be doing everything we can to make sure that this fund persists and providing every other option we can think of to those who also need this resource. So rest assured, it's not going away anytime soon. Thank you so much. And here's our email. I'm going to pass it on to Mark, and then we will have questions available to answer at the end.
Thanks, Sam. Hi, everyone. I'm Mark Conagini. I work with the Behavioral Health Administration. I use he, him pronouns. I'm the director of the Adult Behavioral Health Continuum Division. And I'm going to talk about our new system of how we get money out to communities. It is our BASO system, and it's support, which is a horrible sounding acronym, right? Ugh. Behavioral Health Administrative Service Organizations. What we came up with a better acronym is Colorado LIFS, which is linking individuals and families to services. The Colorado LIFS network are the providers throughout Colorado that our BASOs support, okay? So I'll jump in with, again, I'm here with partners from Signal Behavioral Health Network, Jen Conrad and Meg Taylor from Rocky Mountain Health Plans, and they'll talk as well a little bit about this, and we want to make sure we're available for questions. But I want to give a little history lesson of how we moved to this model. If you look back in time, you know, the governor worked on a transformation council to say, hey, we're spending a lot of money between Medicaid and other sources on behavioral health services, but it doesn't feel like we're getting as much bang for the buck as we would like. And as we dug into that, we found, oh, there's some reasons and there's some efficiencies we can gain by maybe doing things a little bit different. So first, it was the creation of the BHA, which is the Behavioral Health Administration, to have a commissioner, Danette Smith, who sits on the cabinet with the governor. So behavioral health is being elevated in the sense that we're recognizing that all these other state agencies, whether it's Department of Corrections, Public Health, Department of Education, Division of Criminal Justice, all these different state agencies are spending a lot of money on behavioral health. We need to have a voice and some leadership around what's a good direction for the state. And the creation of the BHA was one of them, and one of our first charges was to say, before we figure out how those other state agencies can kind of get them some guidance and direction on how best to use their money, why don't you get your own house in order? Because you're buying services a lot of different ways, which was very true. So I don't need to read all those slides, you can see it, but in the past, we bought substance use services one way through regional managed service organizations using a map that was created 30 years ago. We contracted by statute, we were allowed to buy mental health services from community mental health centers. That's the only people we could buy mental health care from, was just those facilities in the state. And then we created statewide crisis services. After the terrible tragedy at the Aurora Theater shooting, we kind of came together and said, hey, we need to kind of have better frontline stuff. That included things like a crisis call center, which is really now 988, and there's distinct funding from all of our phone surcharges for that, but that's connected to a bunch of other regional services. Now, we built a regional map for crisis services that at least aligned with the Medicaid map at the time, but it didn't align with our MSO map. It didn't necessarily align with the map for the 17 at the time community mental health centers. So we're buying things very differently. Now we have our BASO partners of Signal and Rocky, and this is the new map. And this, if you were in the presentation from Medicaid, is the exact same map that they're using. So we have the state in 4 different regions. So they work through regional accountability entities, RAEs, a drop of golden sun, as you know. And Meg, who is our BASO, also happens to be their RAE. So she gets a foot in both camps and being able to deal with the Medicaid funding, but also deal with our funding. And I'll talk a little bit about how ours is a little bit different, or a lot of it different, actually. So you can see the regions. Signal has region 2, 3, and 4, okay? So landmass-wise, Rocky wins. Money-wise and people-wise, Signal wins, right? They've got a ton more lives and people and communities in their regions. Rocky has the challenge of long distances, remote access, all those challenges. Everyone's got different challenges, right? So the reason we're going to this, fewer steps. I mean, we're really trying to think about the consumer, but also the providers as well. Instead of a provider having to contract directly with us as a mental health center, and then through an ASO for their crisis services, and then through the MSO for substance services, oh yeah, and also for one or more RAE, for all those services, they're working with a RAE, and they're working with their BASO now, right? So we want to streamline that process for them, but more importantly, help people find care. You know, there's people that might be commercially covered. They may be Medicaid covered, or they may have no coverage. And we know with federal landscape changes, there's going to be more people with no coverage, which is going to be a greater impact on our BASO system. But regardless what your situation is, if you're in Colorado and you're struggling, and I don't know where to start to find care, yeah, you can take out your insurance card and try to do that, and certainly do that, right, if you can. But if someone just doesn't know, they can call our BASOs, and our BASOs will offer that care navigation to help connect them. They'll ask those questions. So do you have Medicaid coverage? You do. Let me look you up. Let me see who your RAE is. I'm going to do a warm handoff. I'm not going to give you another phone number, right? I'm going to make sure a human being helps you find the type of care you're asking for, right? You have commercial insurance, we can do some work there too. We can make some connections for you and help you connect and get what you need. And if you don't, we'll take care of you, right? We will help find you and link you to the type of care you're seeking. Some distinctions between the RAEs and the BASOs. The RAEs, again, is member-based, right? It's covering, it's an insurance plan for people that have Medicaid. Well, they have some funding that can support things like, you know, access expansion, et cetera, but they're an insurance provider basically to support people. They do care management, certainly, but they're paying for people's behavioral health and physical health care services. On the BASO side, we don't do the physical health stuff. We're only focused on the behavioral health. And we certainly do the care coordination piece. We do have funding that can support people who are uninsured, like they're uninsured, below 300% of federal poverty. We have financial support that will help pay the cost of that services. But in large part, their client is not just the people, but it is the region itself, right? So they have a responsibility to assess the region. What are the gaps? Similar to what ROACs are doing, right? But you're in a narrow space of opioid abatement limited activities. They're looking at the full behavioral health spectrum, identifying what are the needs, what are the gaps, and then working with advisory councils in each region to help prioritize how do we work to fill those gaps. And partnerships are going to be key. Our federal dollars are also at risk. We saw the cuts to Medicaid. The state budget is exceedingly tight and not a good situation. We're playing defense. We're not in a growth stage. The days of ARPA where we can give money to lots of grantees, and by the way, that happened the wrong time. I mean, it was a pandemic, right? It was a responsibility. We can't time those, right? But we wish we had a BASO system in place so that we could have been more thoughtful and strategic and run that money through our BASOs to coordinate it all. Because we were buying substance use through our MSOs, crisis through our ASOs, and then mental health services through the CMHEs. And then we got ARPA granting, and we managed, 80 different grantees for that directly. We want to run it as many things as we can so that our bosses can really coordinate it at that community level and make sure they're linked together. And this just gives you a sense of the overall budget we're dealing with. We have, $11.5 million in federal mental health dollars, 14.5 in other federal discretionary grants, 21.2 in federal SUD. That's about 155 in state for a total of 203. Okay, so sounds like a lot of money. If you were in the presentation for Medicaid, it's not as much as them, right? They have a lot more. This is the dollars that we spread out through our bosses, and then we entrust them to manage. And in the substance use space, I'll let them come up and talk a bit about what they prioritize for those dollars. And hopefully we should have time after we're done with these last two slides to have some conversations about how our BOSO system works with community.
Great, thank you.
Thanks, Jen.
All right, it's not often that I hold a mic, so hopefully I'm not too loud here or quiet. Good afternoon, everyone. I'm Jen Conrad. I am with Signal Behavioral Health Network. As Mark said, one of the BOSOs for Regions 2, 3, and 4. Meg Taylor, my counterpart with Rocky. So I wanted to just share, so as Mark described, the BHA contracts with the BOSOs as the entity to really contract with the networks of providers, work with communities, and hear what the unmet needs are, and do what we can to respond to those. I wanted to take a few minutes to just highlight what are the services that we then work with our provider networks to provide. So not going to get into the mental health services or the crisis or crisis adjacent services really specific to substance use treatment and recovery services, really looking at the continuum of care. So working with and contracting with providers for withdrawal management services. We have 2 different levels of care there. Looking at or contracting with providers, many of which are in this room today, for residential treatment services, where we have 3 different levels of residential care that we are responsible for. In that space, we do have specialty programming that we contract for as well. So STIRT, which is a program really specialized for folks coming out of prisons or jail, so on probation or parole. We do have folks that are also receiving STIRT programming that might be coming out of problem-solving courts. We do have a couple agreements or spaces where we do receive referrals that way. So that program is really specific to the needs of that population, program that's really tailored for those individuals. We have the CIRCLE program, which are for individuals with more complex co-occurring needs with substance use and mental health, sometimes also more comorbid medical needs as well. And then one thing that we don't have on here is also Special Connections, which is a program specialized for women who are pregnant and parenting and want to be able to bring their kiddos with them into treatment. It can often be a deterrent for women seeking care, and so it's a way to get them and their families the support that they need. Medication-assisted treatment, we've got in a variety of different spaces, levels of care, mobile units to get into more rural or mountain areas where access is a little bit harder. And then outpatient services, both high-intensity services, partial hospitalization, IOP, into more kind of routine outpatient care. And of course, recovery support services, so peer support, as well as other services for pro-social activities, really, really creative, cool things that are happening out there. So really fabulous partners. I see several of you in the room there as well. In terms of other populations that we work with, as Mark said, we do provide care coordination, both for individuals who are involuntarily committed to treatment. This is youth and adults, work alongside the BHA to support those individuals throughout their civil commitment, as well as those who are contacting us. So community partners, family, individuals themselves may contact us looking for services and supports. How do I access care? Do you have insurance? Do you not have insurance? Is your insurance limited in terms of what it will cover? Have you met your benefit max and now you're kind of struggling to access those services? That's where us as BASOs can really help people connect to providers that we contract with, and as well as other providers, but really looking at leveraging our provider network to serve those who are uninsured or underinsured, to get them connected to services and supports. I know we're almost out of time, so I want to wrap this up. I won't read through this, but you can just see who some of our highest priority populations are, meaning if an individual, our contracted providers are expected to prioritize these populations of people because of their increased risk and level of complexity, needing to really, again, prioritize these individuals and their families into services and into care. I think that's my last slide. Perfect. So I want to just open it up at this point. One thing I do want to say, I think Mark mentioned this, is I think for any of you, whether you're providers or you're part of the ROACs, I think a really important piece to drive home is that, as you can see, there are a lot of different things that we are funding already as BASOs and providers and partners that we work with. So as the counselors are looking, as the councils are looking at how to invest funds, what is needing to be developed and built out, please reach out to your BASO and collaborate and partner, so that, as we have been talking about already, funds are quite limited and they're only getting more limited. So with a decrease in funding, please, let's collaborate, let's coordinate, let's see how we can have those funds go further together. All right, should we open up to questions? Great. We have 5 minutes. And Mark says we can go over.
I'm just curious. I would love to hear you talk a little bit more about why priority populations are people who use drugs by injection as opposed to folks who smoke, snort, all that fun stuff.
Great question, and it really comes from our federal funder at SAMHSA and is historic. And it is largely based on a couple things. The risk of spread of infection through needle use was the primary reason why that is prioritized, and pregnant women, you can understand as well, of saying, all right, that's an impact for the fetus as well, so we want to, prioritize getting access for those people, because it can not just help them, but it can help have a greater impact. So again, someone who may be using, substances by a different route of administration, services is still covered. That's priority admission. Most pregnant women are going to be Medicaid covered. So our system isn't paying, but if you're a Colorado Lifts provider, I don't care who the payer is. If there's a pregnant woman that needs service, they get to the front of the line, right? Pregnant women who's using their drugs by injection is number one. So that's where that prioritization is for access. Our funding is really supporting people with substance use disorders who are uninsured or underinsured, below 300% of poverty, right? So it's not going to say you don't get care and you do get care. It's going to say if there's only one residential slot, that person gets it first. That's what that prioritization means. Good question.
Thanks. I just wanted to piggyback off of the comment about insurance covering naloxone. So I work at Arapahoe County Public Health, and we utilize the bulk fund for our harm reduction clients and love it. It's very helpful. But for our nursing programs, we've wanted to distribute naloxone to folks who are reporting drug use and could benefit from it. And we've just really struggled with actually getting reimbursed by Medicaid, and have reached out to CDPHE, and they don't really know the answer. Medicaid itself isn't actually that helpful. It's kind of a trial and error system with Medicaid. So I don't know if you have any ideas for other technical assistance, or if there's anybody else in the room who has been successful in billing Medicaid for naloxone, but we just have not been able to get reimbursed.
Thanks for bringing it up. Do you? I could take a stab because it's in the insurance realm, right? I've actually brought this very same question up. It would be one that I would love to see the naloxone work group of the consortium really just take on, because they have pharmacies there, they have others. Right now, it's something available through the pharmacy benefits, so you have to go to a pharmacy that, you know, is able to bill Medicaid for it. So there are certain providers, certain FQHCs, certain safety net, comprehensive safety net providers that have, like All Health Network, I think, they've got their own pharmacy. So those types of organizations, because they have a pharmacy, should be maximizing that. You know, again, you can't just order it in bulk and then give it out willy-nilly. It has to be associated to a Medicaid member, but that would save so much of the bulk fund if we could do it. So I recognize it's a real deal. I would love to see all of our syringe service programs in Colorado, because harm reduction is a really important, critical part of the continuum. Someone who dies of an overdose can never achieve recovery, right? So we need to keep people alive and meet them where they're at. So regardless what we may have here federally, that's a huge portion of it. And it would be so great if all those organizations could somehow find an affiliation with a sponsoring local pharmacy that could help with that in some way. So if we're able to get the patient's information, their Medicaid number, but I haven't cracked this nut and I haven't figured out how, but it's a real issue that could really help us make our money go further. So I would love to see if people can get their heads around this.
Thank you. As someone with a hospital system, a nonprofit hospital system, sometimes we have a difficult time getting naloxone from our community partners. They've either allocated them to some other organization and they don't have any left to give us. We have emergency rooms. You might know that people with overdoses come to emergency departments. And I am just wondering what the thinking was in terms of excluding hospitals from being able to get naloxone from the bulk fund, and if that's a possibility that we could in the future get it.
Sorry, you said nonprofit hospital system?
Yes.
So the exclusion is primarily for-profit. So I don't know if you've ever applied for the bulk fund, but that's something I would consider having a conversation with us about. One of the things that, and I can have Jericho speak to this a little bit more, but we also recognize that particularly in rural areas or more isolated areas, sometimes a hospital in the Denver metro that is characterized similarly as a hospital in a rural area does not have an equal amount of resource, right? They may be the sole resource. And so those are some of those conversations that our team really will approach one-on-one. So if you were to go on our website or even email us directly on the email that we shared, we would then typically either email you or call you and just have a conversation based on your own circumstances. The reasoning, to kind of speak to the hospital piece in general, the reasoning for really kind of eschewing specifically more clinical spaces and more specifically for-profit spaces is we were already at the onset of the bulk fund creation really trying to make sure that this was going to those who had fewer resources financially and were also working maybe in environments where they weren't being able to access a lot of funding to that regard. So we know harm reduction has been under attack for a lot longer than just the last year, right? It's been increasingly incredibly hard for those organizations to gain funding for drug user health items. And so really trying to pivot that resource towards those who we knew had less ability to maybe prioritize it in their own budget. It's imperfect, obviously, and we have these conversations regularly. It's also statutory, right? So the list was developed in statute before it even hit CDPHE. So I can't speak to all of the logic involved, but I will encourage you specifically to connect with us because there is nuance there as it relates to the kind of spatial places that you're working in, and if you're for-profit, nonprofit, and the resources at hand. Jericho, did I cover that decently, or do you have anything else you want to add? All right. Payer of last resort. Yes, yeah, and that's a good point. So the bulk fund, typically we advocate that we are the payer of last resort, right? So that also means we encourage you to find other options, but we are the payer of last resort. So if we are your last resort, we're your last resort. And obviously we have limitations in terms of eligible entities, but if you are eligible, then that's something that we can absolutely support you with. And hopefully that was helpful.
And I know we're at time. We might have an opportunity for one more question. We'd love to have a question for the Western Slope so that Meg can share her expertise.
I'm fine if you don't have
Okay, we got one.
Oh, yeah.
Oh, wait, there's one there, and then we'll do the second one there.
So my question was, we previously were on the naloxone bulk fund, and then I think it was last year we were no longer accepted on the program. We reached out to make some type of amendment to actually state our case of why we believe we should be remaining on there. Could you talk to me about the process of reaching out, and for those who may have been on the program before that are no longer on it, how we can kind of have that conversation with you?
Can you let me know what organization you're with or what your classification is?
Sober AF Entertainment, nonprofit.
Sorry, say that one more time.
Sober AF Entertainment, we're an
okay.
RCO nonprofit.
Gotcha. So you're still, anybody who was enrolled as an eligible entity is still an eligible entity. What is in place that makes that difference is the prioritization plan. So the prioritization plan is a tool that we have activated because of our lower amount of funding. Mm-hmm. So you're still eligible as soon as we have additional funding that can accommodate those other tiers, right? And so these tiers are based on basically knowing that when all else fails, the evidence is behind getting this naloxone to people who are using drugs, right? So that's prioritizing organizations that are working directly with people who are at potential risk of overdose or at potential risk of witnessing an overdose and responding to it. Now, your organization is a great example, right? We know that people in recovery could potentially be at risk of relapse or return to use, or they may still be in friendships or network with people who are using drugs. And so there's definitely gray areas there. But my understanding is that we're also looking at where are your distributions happening? Is it at an event, or is it during the course of your direct services? Is it during tabling? Is it at a baseball game? Is it very targeted and intentional? And so if you look at our prioritization plan, and you'll see also kind of citations and evidence that we're pulling from here, because we recognize that your work and having naloxone in your hands is incredibly important, but we have a limitation of funding, right? So that who is able to order from us, who is kind of on the tier that we're able to supply to, will change based on our plan. Say we have less funding available, we may pivot to just tier 1, right? Rather than tier 1 and tier 2. It's not to say that your work isn't important, it's just because we see a very direct distribution occurring. I hope that's helpful. I know it's also been a sore subject because I feel like it, in some ways, feels like it lessens the sense of impact. But that's not, it is coming from a very fiscally necessary continuation of the bulk fund and our best evidence on how to make this most impactful with that lower distribution. Did you hear that? Basically what Jericho said was, we know that Sober AF also is collaborating with a lot of community partners, and that is kind of what we spoke to earlier, which is who can you bring in? Who is that direct service provider? If you're interfacing with people at an event and they say, we need this, then do you have that connection with a partner who can provide that support and service to that individual? That creates a much more direct linkage. I know we're over time.
All right. Thank you.